Hey everybody, welcome to Ask the Anabolic Doc, starring Dr. Thomas O'Connor, brought to you by his websites, anabolicdoc.com and metabolicdoc.com, both of which you can get his book, America on Steroids, A Time to Heal, which is also available on amazon.com. The doctor is looking tanned and well-rested. You've been away for a Maine? You had a little vacation, Doc?
It was unbelievable. Went up to Rockland, Maine.
Yep.
Way up north, even up to Belfast. And, oh, got way up there. Went out to the islands that are 7 miles off the coast called Vinyl Haven.
Okay.
It's an old school granite, quarry place, and it's a fishing island. And I was able to just think.
Yeah,
so it was good, man.
I hope you got some downtime and just relax too.
I did, man. It's the downtime is there, and when you're out there alone with the seagulls and your sweetheart.
Yeah. Right on. Okay.
It's good, man.
I'm
ready for today, though, baby. I'm ready to rock.
How's this all going on? How's
it's okay.
Yeah?
I don't want to even show
it.
No,
don't flex. Don't do any of that stuff today.
It's pretty atrophied, and it's 3 weeks tomorrow out of the operating room, and man, it's anchored in there, but it's sore. It's good. I keep it limited. I do wear the brace, for the doc, and I'm out there, and I'm getting better, but man, it slows you down, guys. Injuries are tough, but what are you going to do? Yeah,
well, you'll bounce back. Okay, I want to get to the questions because this is the main question I think we're going to talk about today. Something I've never even heard of, but this is fascinating. So let me read this. This came to us from Squat Junkie. So thanks, Squat Junkie. This is a good one. Testosterone resistance is overlooked in our medical community because it allows for a man to have normal levels of testosterone and still have all the symptoms of deficiency. This was a quote from Dr. Keith Nichols. And he gave a link here to, I guess you'll tell me what this is, a study or a paper that Dr. Nichols wrote. He said, we all know about insulin resistance, but I only heard recently about testosterone resistance. Does the anabolic doc encounter patients with that condition? What are the causes? Dr. Keith Nichols mentioned zinc deficiency, PA. I know someone can be short on androgen receptors and as a result doesn't respond to testosterone like someone else does. I think that's bro science. I'm not sure that's an actual thing.
Yeah.
You can correct me. But are there any other causes? How can it be treated? I'd like to hear the doc's take on this. Squat Junkie, testosterone resistance. What the hell is that, doc?
Awesome. right off the bat, it so much comes into my mind, and there's this this spectrum from anabolic steroid users to men on testosterone, right?
Yeah.
So testosterone is just physiologic doses, and then you have men that are using. I heard of a guy 2 weeks ago that was using 4 grams a week of equipoise on top of a lot of other drugs.
Right on. Okay.
Okay. So. Let's take it for what it is. This is let's talk about the medical side.
Yeah.
So resistance means that you have a substrate, you have a signaling molecule, say for an example in diabetes, and then you have receptors. So if diabetes, which is brilliant, and I did check out this Dr. Keith Nichols, and I saw there was a book associated, and I don't want to get too much into that.
Yeah.
A lot of stuff's promotional stuff, but this guy's a very smart guy, and he's touching on some stuff that it's been out there for a while. Okay. The mainstream, doctors don't know it, but of course that's the bridge and the edge of what we're into here. So insulin resistance. So impaired fasting insulin, impaired fasting glucose, it's called IFG, pre-diabetes. Okay. Your insulin's going up because your receptors, they're tyrosine kinase receptors in the gut, and the insulin's knocking on them, and they're not receptive. They're getting dulled. And that's what happens with the genetics with humanity as you get older with genetics, and your abdomen, the fat in your visceral cavity becomes greater and it's very active. You become diabetic. Insulin levels go way up in the beginning, and they're not receptive. So that's insulin resistance. Perfect example. Let's go to testosterone.
Yeah.
So I've seen, here's the number one, this is for Dr. Nichols too. I hope he's listening. The number one legitimate cause or example of testosterone resistance is anabolic steroid-induced hypogonadism. And this is what I've been regarded and known to research years ago. And there's other experts in the world on this. There's a limited number, but I'm one of the guys that I deal with who? Anabolic steroid users use anabolic steroids, which mainly testosterone and other anabolic androgenic agents, right?
Yeah, yeah.
After they use it for years, for an example, we know the hypothalamus and pituitary and the gonads essentially disconnect. Now, think about this. This is part of the resistance. Now, when they come back, when an anabolic steroid user stops the use of steroids, what happens? To a greater or lesser extent, the hypothalamus, pituitary, and gonads will reconnect either fully, partially, or not at all. And that's called anabolic steroid-induced hypogonadism, correct?
Right.
Okay, so what we're getting to with this right here is this. I have seen, and in the literature, it's widely reported for years now, men will come back after using steroids. Their testosterone will come back on paper to be 400, 500, maybe even higher. Now, there can be a disparity between the total and the free, which we can get into in this question and other questions.
Yeah.
But now, there's the example. Think about this. They have normal testosterone, but they feel horrible. Mood and libido, they have bad quality of life, Ron. So, and this is what we're teaching doctors. It's not just a number on paper. When a man has been exposed to androgens in his central nervous system, his system on paper may come back to a greater or lesser extent. But the fact is, the exposure to his central nervous system, say he's been living on a gram of testosterone or 500, have you ever checked the levels? You know it says 2,000 or 3,000.
Yeah.
So the brain, and this is we could talk about the brain right now, then we can go into the skeletal muscle. The brain becomes resistant. There it is. So something happens in the brain. This is, when I saw this question, I thought this is perfect segue into anabolic steroid-induced hypogonadism. So the testosterone levels are normal, theoretically, 400, 500, 600, they're normal.
Yeah.
The free levels can be normal too, but this man has been used to living on levels that are super physiologic. So there is, by definition, some type of resistance in his central nervous system that there's a downregulation, there's other molecular changes in the synapses in the nervous system, there's a lot of protein changes in the neuron, in the androgen receptor that's in the neuron in the central nervous system in the limbic brain. That's why, guys, this is why my business is relevant and I'm so busy. Men come off steroids. Now, a lot of them come off steroids for 6 months, a year, not in the short period with PCT. That you have to give men time. But after a year or two, a man's testosterone never goes higher than 100 or 200, and he feels like garbage. Now, that's going to be not really resistance. That's because his brain in the hypothalamus pituitary area is just completely shut down forever.
Wow.
But the resistance is when you see, and this is the problem, and we're coming out of this, and I'm so happy that I'm able to promote this and just do it and promote it in a ethical way, and not giving a blessing on steroids for muscle building, but because that's what the regulators and the licensing doctors are listening to me. I have so many doctors calling now. I'm working with doctors all over the world because they're caring for men that are suffering on steroids, and I'm so happy to say that my fight and my years, 10 years coming up this spring of 2019, 10 years of fighting for these men. It's finally happening. Doctors are accepting it. They're not pushing them away. And now we're answering the questions. How do we do it? What are the mechanisms? And where do we go? And then, of course, always educating young men. Hey, man, if you don't want to go into this world, don't go into it. So do you understand that, Ron, the resistance?
Well, I'm trying to differentiate between anabolic steroid-induced hypergonadism and actual testosterone resistance. What's the difference? Because one can be treated, and can testosterone resistance not be treated?
So, repeat that again, Ron. Sorry.
Okay, so you treat a lot of men with this anabolic steroid-induced hypergonadism. They're
Yes.
never going to, you know, like myself, I'm never going to be able to produce ample amounts of testosterone again because I used a lot of synthetic steroids, you know, testosterone for years. But, you know, most of your patients do very well on TRT. You give them 100 or 200 milligrams of cypionate a week, and they're good. They feel great. But it sounds like this is something much, much worse.
Wow.
Where you could give someone like this, someone with this condition, is it a legitimate condition or is it just a theoretical thing? Is this actually been, is this something that's been, you know, it's in the literature, it's diagnosed?
So apart from steroid users, let me digress a little bit. Apart from steroid users where they do respond, now I've been doing this for 10 years, they respond to various doses of cypionate and esters of testosterone, as you know, cypionate and enanthate, not really propionate, Sustanon 250 all over the world, and there are other mixes of esters. And what you see is, I'm going to say something very specific. You see a disparity where you see the sexual and binding globin becomes overloaded, and you see a higher free testosterone versus a total. It's a flip of what we're talking on the diagnostic side. Now, those men feel 99% after 10 years, those men feel great. You really don't need to give them. So I will tell this doctor, I have the data on my side, that you don't need to, for the most part, overload these guys with 400 to 500 a week of you don't. Now you need to give small doses, sometimes every day or every other day. Remember, for the estrogen and for the so you don't get those peak and troughs. But most do well. The men that don't do well have psychiatric disease.
Wow.
They have depression. There's something else going on. And I'm talking about in the end where they have a bad libido and they need more and more and more. And this is apart from guys that are making it up and wink, wink, doc, I'm really not feeling good. How about some more? Yeah. They don't come to me for that. They can get steroids. They're not ready to come. So the other issues are this. What this may relate to that no one knows. You're talking about congenital issues where the receptors are either non-existent, Ron, from a congenital standpoint, which we can go into primary, secondary hypogonadism, but these guys aren't hypogonadal because he just said they have normal testosterone levels. Yeah. So this is something new and I don't know about this. So what this brings to mind is other organic cases or congenital issues would be this. Congenital, you'd have to think they're very rare. I'm not saying it's an excuse for this guy to say testosterone optimization and we're going to live on all this more testosterone. The majority is I take care of men that are massive steroid users that are completely shut down. And I rescue these guys with pretty small doses of physiologic androgen, Ron.
Right.
So now, again, there's a much high, in the end, I've discovered that the free testosterones are much higher and out of range slightly, super physiologically, to the total. And that's because of the ester, and it overloads, and this is sustainable and permanent. It overloads the binding globin. Now, this is very high talk. This is bro talk. Guys who love the show, or what I just said right there, they're going to get it and go, wow, I've discovered this. They've seen it too. Yeah. So in the end, I make sure the levels are upper limit normal. Everyone's normal. Everything's fine because I have a medical license. We can't give steroids. We are rescuing men, and only men only, that have been damaged from the use of anabolic agents. It's very straightforward. What's the damage? It's uncharacterized, and it's in the hypothalamus pituitary. It's the testicles. That's the primary site. Those can be damaged because they're just shut down so long. They're atrophied, and you know they don't come back.
Right.
So the other issues would be this. I like what he's saying. Zinc and other metabolic causes, diabetes, zinc. So think, when something else is, the receptors are not working and they're overloaded, there's a downregulation, Ron. There's upregulation. This is real science. Bro science is, these guys are certainly great at understanding. Now let's segue to steroid users. Ron, yes. Why do steroid users cycle? Why do they come off? Why do they stack? Tell me.
Well, you would want to come off, theoretically, to give your organs a break, let your liver enzymes come down, try to minimize damage to your heart, your blood vessels and all that. You know, trying to do the right thing and minimize long-term damage, I would think. Why do we stack? Because we get better results using multiple drugs at once.
Right there, right there. So multiple drugs. The community, the steroid using community for the last 40 years has understood man per man, every man's different. There's some similarities. There's some great stacks, Test, D-ball, equipoise. There's some classic combinations. Yeah. But when you hear this, that you've heard, because you've been in the community for decades, and me, I've been on both in the community underground and as a physician, when you hear the changing stacks, and then you hear men that say, shit, doc, I'm on my old stack and I'm getting weak. It's some kind of a myopathy.
Yeah.
Now, I've actually referred men that are on steroids that they're getting weaker. Now, this is going to ring a bell with a lot of guys listening to this. I've referred them to neuromuscular experts that are neurologists, and we've biopsied their muscles to see if they have some issue where their muscles, skeletal muscles, are being toxic and breaking down. And there's literature, this is very arcane, there's literature that steroids, funny enough, it becomes a paradox, and it actually can damage. We know that you can have muscle tears,
right,
because you get so strong, and no orthopedic surgeon has ever given me a straight answer, because the tendinous muscle belly region is disorganized, and the muscle belly grows so disproportionately. The weak link tears. It's mechanical. Right. No one's going to argue it, and steroids can enhance that. And there's genetics, and there's other issues, and there's medical issues, and age and related. So because when you get older, you tear things anyway.
Yeah.
But when it comes to this resistance and skeletal muscle damage from steroids, I've seen it. Now, that's what men, they come off and they clean the receptors, Ron.
Yeah.
With Benadryl, guys with histamine. Ron, you know you love this.
Yeah.
They clean the receptor. Hey, so guys have these, you could Google clean receptors, agents to clean receptors, anabolic steroids. In the beginning, when I was the Anabolic Doc, 2005, 6, 7, before I was writing in muscular development, I was getting all these questions and guys coming in, Doc, what should I use to clean my receptors? I'm using histamine blockers, type 1 and type 2, Zantac.
Wow.
They're doing Zantac. They're doing Benadryl, Atarax. Guys are coming off. It's just, and there's literature for it. And the anabolic doc, that's out there, in Greece, if you will. So I've heard of this. Yeah, Dr. George. So it's Dr. T. So this is great, and it's unknown, and it certainly leads to the point where we need to study these things for humanity and for people just to do well. So my last note was, because I wrote this tolerance is depression. I'm telling you that when you see a man with normal testosterone, Ron,
yeah,
you give him testosterone, and the levels go up and up and up, and he still does not get the response that we're looking for, which is he feels better and he's horny in his libido, and mood and libido, always. Energy levels, blah, blah, blah. But I'm telling you, as the anabolic doc, metabolic doc that's seen thousands of patients for over 10 years, those men, and I'm being very cautious, but I'm being very true in my data, they definitely, at that point, have some brain changes in their CNS, and I just call it psychiatric. It's again, I'm not disparaging.
Right.
They do. And then what do you do about that?
Yeah.
I'm not saying it's easy. I have to work with psychiatrists, psychotherapists, and we sometimes do use. That's why I work. People pay me to be a manager. Yeah. I just become your manager because I don't do this alone. So I work right now with at least dozens of other psychiatrists, because these are men that have anxiety and they have depression, and we need to use psychotropic medicines. And we find a balance, and we use cognitive behavioral therapy, which is called talk therapy, So there's a couple docs. There's a medical doc like me, there's a psychiatrist, and then you have a PhD psychologist. And we integrate those. And let me tell you something, we could have great outcomes. But that's where this resistance is. They're seeing it wrong, that it's not an actual resistance in the receptor. It's because there are other issues in the central nervous system. Again, this is not muscle. Hey man, I need to bench 600 raw, and I'm hanging at 575, and my stack of test and anadrol and D-bol and equipoise is not working. I need to clean receptors. Wow, that's the skeletal muscle. We're talking the CNS for mood and libido and why testosterone levels. I've seen guys up to level, doc, I'm on 1500, 2000, and I've been down as low as 400. I've seen men in this world, God bless them, I feel sorry, that, and this is after steroid use though, typically, but not all. Some men come to me, they're suffering and they just feel horrible. And they go from 100 milligrams, 200, 300, up to 4, 5, 6, a gram, all the way across the board. I've watched them for years, at least a year, 18 months, one example in the UK, and he never feels, he's not horny low, medium, or high. What do you say for that? Receptors, he has depression. He has something in his brain.
Let me ask you this, doctor, because this is, obviously that's a very serious subject. I'm not trying to downplay the how a person feels or anything, obviously, but what about, physically? Have you encountered men who have become resistant to testosterone to the point where no amount, let's say a guy was blasted steroids for years. He's 5'10" and 270 pounds, and he maintained that for 15, 20 years. Then he goes on TRT or whatever. Well, let's just say he doesn't. Let's just say at some point he starts to lose muscle size and strength, and he ups the dose, and he still can't, he's still losing. Is there such a thing as abusing steroids for so long that you shut down their ability to work at all? Like, there's no amount of steroids that are ever going to be enough to make a person like that big and strong again. So
Ron, that's what I mentioned 5 minutes ago.
Yeah.
I've seen a rare number of cases of men that have come to me and said, Doc, I can't bench freaking 225 for like more than a couple reps right now. I used to bench 405 for a couple reps. Yeah. So that is neuromuscular pathology. So, and there are case studies, Ron. I've realized this. I've been dealing with this for 10 years. So they're rare. Now, but on a common side, that's why men cycle. And that's why men cycle. And then as you get older and things change, there's so many variables, it's so dynamic. Every steroid user that's experienced will right now chime in and say, the doc is 100% on the money. Because even for these guys, they're going to say, wow, man, that old cycle of a 750 a test, of 80 milligrams of Anavar and one Anadrol a day, that used to get me up to benching four. I'm talking mainly strength and power lifters. Those are my, the bodybuilders, there's so many other drugs with insulin and stuff involved. It becomes so complicated. You just can't, I can't tell. It's polypharmacy.
Right.
So but these guys, I've worked, men have hired me, this is years ago, and I've worked with neuromuscular pathologists, and we've biopsied them to see if they have inborn errors in their skeletal muscle is breaking down. We get CK levels. We look, and their muscles have been in disarray. Now, this is a man. There's 3 men probably, I remember, only 3, and I worked with expert academic neurologists who biopsied the vastus lateralis, and we found they had disarray. They had abnormal skeletal muscle on biopsy. Now the answer was why? If you look at the data, there are case studies where anabolic steroids have paradoxically damaged and weakened skeletal muscle.
Wow. But that's very rare, you're saying, right?
Super rare. Super rare. You just and again, I was very interested in that years ago, and knocking on wood, I haven't seen a case of this in more than 5 years.
I mean, it just seems insane that a drug that people use to increase lean muscle tissue would decrease muscle tissue.
But Ron, think about it. Think about the evolution of our body and mammalian physiology. It's a balance, Ron. For every action, there's an equal and opposite reaction. There's upregulation, then there's downregulation, on, off, up switches, molecular switches. It's super, and I've talked to molecular biologic PhDs in molecular biology and the skeletal muscle guys. These are genius guys. They're working on mammal studies. There's been a lot, unfortunately, they've juiced up a lot of dogs and they've checked all this. It's true.
Hopefully no poodles.
No, not poodles.
Or Shih Tzus.
Both.
Yeah, damn it.
So it's so what else? What else did I want to see my notes that I jotted down? That's, so the receptor, and so, okay, another thing I want to say on this is that with something that could skew the picture is other medicines. Mm-hmm. So there's polypharmacy. So I see this not just with steroid users and TRT, guys that are on opioids, Ron, other medicines. That's why doctors need to take a proper history. Other medicines can be involved. This is very complicated. The history is important. Depression, opioids. Men that are on opioids have rip-roaring low testosterone. It impairs that in the central nervous system. Corticosteroids, Ron. I made a lot of notes. I've seen a lot of men come in on prednisone for various reasons. Prednisone, corticosteroids, those also demolish the testosterone, and they can impair. If you're on Suboxone, I have men right now, many, dozens, on opioids for chronic pain. I don't give it to them. They have another doctor. Right. They're on chronic pain, and I'm not disparaging. I'm not talking about it. They're on them. They have a physician giving it to them. They're being managed by a pain doctor or another doctor. And they're also men. Now, so giving testosterone to a man who's on pain medicine, who's on narcotics, in addition, I have men that are on Suboxone. You know what Suboxone is?
Sounds familiar.
Suboxone is a medicine. If a person is suffering with opioid-related chronic pain and they're suffering from narcotic use and their life is destroyed because they're addicted to narcotics, we use this. It's a medicine that gives them. It's like methadone.
Oh, okay.
And I am no expert in this stuff. But I'm a doctor, and I take care of men that are on them, so I understand this. So we give methadone to men and women that to get them off illicit narcotics. This is my whole take on why do we blow off steroid users when we're taking care of these people?
Yeah.
There's no answer ethically on that. Otherwise, you're discriminating on a great class of people called steroid users. There's millions upon millions, and not to give them proper, adequate medical care is 100% unethical. But that's beyond today, and this is my stake every day. So if you're on opioids, if you're on depression medicines, if you're on corticosteroids, if you have other medical issues, and that's it. So, and if you have other medical issues, if you have autoimmune, Ron.
Yeah.
So this is why my life and my practice, I have to be so focused, and you have to be a good internist. If you have rheumatologic disease, psychiatric disease, if you have cardiac disease, renal disease, if you have other medical issues, the grace of God, we're also healthy, Ron. People take it for granted. When you see someone that comes in with a host of medical issues, which, Ron, we do see it, Ron. Haven't we seen it, Ron, with some of the in the emails?
Sure.
So when you see these things, this is what's out there in the world. Just to say testosterone resistance, I'm not putting it down. It's brilliant. It's coming on the forefront, and there's something there. But, Ron, how complicated is a human being?
Well, I mean, the reason it's important that you address this topic is because I think if people just saw that, that term anywhere, a lot of guys would say, oh, that's me. I have that. I'm testosterone resistant because I'm using a gram a week and I'm not as big as I should be. Or, I mean, honestly, I was thinking maybe I'm testosterone resistant because I don't get the results. And, obviously I don't know, I don't have a laboratory. I don't know exactly what I'm taking, what doses, as opposed to, your patients know they get a bottle. It's 200 milligrams per milliliter. I don't know how many milligrams, I don't know how much I'm really taking. Could be this much, could be this much. I don't know. But I think a lot of guys are in my position where if you're in your 40s or beyond and you're still using steroids for, cosmetic purposes, you don't get the same results that you used to. And I think it would be easy for a lot of us to jump to the conclusion that we suffer from this affliction when what you're telling me is it's probably 0.1% of the population, the male population, would even be would even be considered to have something like this. It's that rare.
But if you think, so that is, you said it perfectly. That's that's clinically accurate. But the deal is also this. We always want to get bigger and stronger. Think about it. There's genetics. Look at Big Ramy. I mean, come on, everyone in the world and in this world I've been watching the bodybuilding world even more and more since, being back with you guys for a year or so. Some men do the same steroids and it's genetic. There's genetics, Ron.
Yeah.
There's other, that. So, but what man in this drive, in this bodybuilding world, in the physique world, in this powerlifting strength world, it's amazing. You want more. You want more. So that's polypharmacy, Ron. Now we have steroids upon steroids, ginormous. The guy was adding in just one of his drugs. He was alternating 4 grams and 3 grams of equipoise on top of other drugs. And I mean, I can't tell you that I've really heard that, but that's out there more and more. And that's on top of insulin, clenbuterol, SARMs, and peptides.
Now, without violating HIPAA, was this man as large as Big Ramy?
No, but no, you know what? But a good look, amazing physique.
Okay.
I mean, amazing physique. But I've seen this on a bunch of guys now. So, I mean, it's just incredible. So people, and then you have these arguments, the scientific arguments from guys that are so out of the loop, these PhD guys that are just old and washed up. Well, there's no data to support that if you do steroids. Remember back in the 80s, Ron, steroids, there was no medical support. They worked.
I have old magazines from the late 70s into the mid 80s, and a few different times I caught them saying steroids are mostly what's that word for something that you think works but doesn't work? What's
placebo? Placebo.
It's a placebo effect. You think they're doing something for you, so that's why they cause muscle growth. It's all in your head. I was like, really?
So this is, people, especially here in America, because I work all over the world and I just hear guys, I mean, we're a great show here. I mean, America is the best show on earth. So, for all reasons, politically, from everything. So, and then the bodybuilders, and then for guys out there in the world outside of America that want to be big and strong, they just look to us. And now the bar is always going higher and higher and higher, Ron. So who knows if guys are actually resistant, or they just gain to the point where their genetics are limited and they're using drugs and you're saturating the receptors. And it's not even just receptors. We're so limited. My brain's limited. We're also limited. We don't know we're not researching steroids and PEDs. We should be, Ron, for humanity, because again, we have elderly people that are suffering from age-related sarcopenia and they fall and they can't get up. And that is pathetic. We should have medicine for people. We should have therapies for elderly people so they can be fit and strong and live at home until a much longer time instead of dying and suffering in a goddamn nursing home.
Well, you just would kill about $10 billion off the top of the nursing home industry profits if you did that. But oh well.
Good point, Ron.
I just made a note. We'll talk about another show because you just gave me another great thing to talk about for another time about cycling versus staying on a blast forever and ever. But we'll talk about it some other time.
Awesome.
Into question number 2 from Derek Johnson. Derek wants to know, can a longtime user, this is a great question, Derek, thank you, have so much scar tissue at the injection site that anabolics no longer absorb properly? And it's a good question because most of us inject ourselves, a lot of us do. And as you pointed out many times, there's only so many places we can reach on our own, unless you're one of those freaks, it's triple jointed or something. But so if you hit the same spot in your delt 1,000 times, same spot in your glute 1,000 times, you probably have a wad of scar tissue, maybe the size of a fist in your glute. What happens when you have that much scar tissue and you're continually injecting there again and again? Is the drug even being absorbed?
It absolutely can happen. And let me tell you what it's called in the medical community. Sterile abscess.
Wow.
So you have, and I see this. Obviously, I'm the anabolic doc. I have guys that join the practice just because they have these big lumps. So you have, when you inject into an area, and everyone who's injected steroids for years has had a bad injection, and is it painful and warm? Is it infected, or is it just a bad area where it's bleeding inside and it's pumped up and it's just elevated and it's is that mass an infection, or is it not? Now, that's in the acute period. So then a good doctor will say, please, be careful, and they give Keflex, or we give Bactrim, or hopefully not Cipro, because those medicines they tear tendons, and a lot of doctors don't understand the fluoroquinolones absolutely should not be used unless you really need to use them, because fluoroquinolones pop tendons. And I see so many patients come in for me with a history of using those, and they indeed have an Achilles tendon rupture, or they have a pec rupture, and I was not on fluoroquinolones when my pec ruptured, so I can tell you that.
Let's repeat that, because I guarantee you a lot of guys here, when they get infections, they run to the Minute Clinic down the street, and I don't think those people are, they're seeing 100 patients a day.
Yeah.
So, guys, Doc just said, Cipro, stay the hell away from
fluoroquinolones. Again, if you have an allergy. Now, these caregivers are good. Yeah. I support these caregivers, even the nurse practitioners. This is America now. We have a massive problem. We have we have no one's going into primary care. I teach in the primary care program, so we have no choice. So again, the EMS. We were in Rockland this week, and a guy dropped. Wendy and I, my nurse, the badass membership specialist, went to the floor, and we were helping him. We were making sure we were doing the ABCs, your airway, breathing, cardiac. We called 911. So the paramedic guys came, Rockland, Maine, man. Those guys came in the scene, took him away. I hope he didn't have a heart attack, but we took care of him. So I'm sitting in the bar, hiding out up in Rockland, Maine, having a drink, chilling out, just realizing, wow, man, I love the seagulls up here.
Is there a doctor in the house?
We were there, man. We were there. It's great. Actually, my girl, my honey, Wendy, the membership specialist, who's a board certified nurse, who's a cardiac nurse. I was sitting around, just drinking my drink, looking around, and all of a sudden, Wendy's working on some guy on the floor.
They didn't have the defib paddles in that bar?
Get ready for it, man. She was all over that. I mean, she does that stuff, unfortunately, like every week, and she works in the coronary artery care, in the cath unit, interventional cardiology at St. Francis Hospital. Little pump out for them in Hartford, Connecticut. Great place. So these people, they treat infections, and it's not always easy to know, is it an infection? Is it just erythematous and it's just inflamed? Is it a sterile abscess? So the truth is, they'll give typically Keflex. If you have an allergy to Keflex or penicillin, they have to give something else. This is where it gets hard. So just guys, people, be careful. If you're a muscle builder, if you don't want to, obviously, and no one wants to rupture a tendon, but if you're putting your tendons under stress because you're training hard, how many ruptures have I seen because patients have received fluoroquinolones? The classic story is a man has prostatitis or a UTI or BPH. He goes to see a doctor, maybe a urologist, and they give Cipro. And then within 6 months, if not sooner, while pop, he has a distal bicep tendon, a pec, or the classic one is an Achilles tendon rupture. And if you read on Cipro, you're going to see a black box warning that says tendon rupture.
Nice.
So again, let the educated consumer beware. That's why I like Google Medical people, Google Medical. I just tell my patients, give me a chance to respond, and if I don't understand it, let me research and look into what you're asking me. Because but if people do Google, they're going to say, look, I heard from the anabolic doc that I shouldn't be, can you give me another alternative? Or maybe do I really need that antibiotic? And the answer may be, here's an alternative, or maybe we can watch it. So when you inject in the same area, here's what happens. Men put in the needle, and they say it's like going into like a block of ice, or it's like going into a matrix, or like it's like going into kind of like a stone, and it goes in, but it's like, it's just really hard. So that is a sterile abscess. That's not an abscess. It may have been abscessed. I have guys that come in, Doc, can you help me out with this? What do you got, buddy? I have had this thing on my ass and my arm for 4 months now, or 6 months now. It's a big lump. It was infected. The body's amazing. it walled it off. It controlled it. He didn't die from sepsis. He's a healthy man. His immune system worked, and now he has a scar tissue. And then what do I do? I send him to a surgeon, and they remove it.
Okay.
So so it is true. So what do you do about that? Find areas to inject. Certain areas are more resistant to developing scar tissue. I think the deltoids are just great. I think most men, you're injecting in that rear end. It's kind of a dicey little area there to do. You're using a bigger needle. I know not. So using smaller needles that are less invasive, obviously, are better. And just there's some genetics on it. Some people will go, I've been injecting for 30 years. It's fine for me. Now, so what the other question was, or the second part of the question is, will you have a problem of absorption in there? Remember the story of the guys that the inmates I take care of in prison, and they were injecting, and they inject in the deltoid and they rub against the wall to make it sponge out. So then they say, hey man, I don't feel good. Send me to the lab and check my levels. And they go to the lab and their levels are low. Yeah. Because it's a sponge. So you're putting in testosterone. It's called a depot. It's a bolus into a muscle, and it leaches out from the muscle belly. It's from the 1940s. This is why the ester. That's why they've put that ester. It makes the half-life go from 2 hours to 8 to 10 days. Right, Ron?
Yeah.
So and there's libido, testosterone undecanate, has a half-life of 6 weeks.
Wow.
Or 4 weeks. I mean, it's once every 2 to 3 months. So, and correct me if I'm wrong on the kinetics, please. So they've changed the ring to slow down the absorption of an oil, and you put it in a muscle. There's so many variables. So, I mean, and some guys inject, and then it comes out the hole.
Yes. Yeah.
Doc, I'm injecting it. All came out the hole. Can you please give me some more? I mean, Doc, how many times have I gotten those questions? Doc, should I re-inject?
I want to know the answer to that. That's happened to me.
Answer is probably not. I mean, so you're losing a little bit out of it. So this is all, I love basic gut questions. If you're injecting and you see the oil coming out, you're definitely losing a little bit, but is it negligible? So what guys typically do is they inject. I tell them, pull out quick and put that, because when you snap it out, it goes quick.
Okay.
I mean, some guys do that, and it's so guys dilly-dally, and it's typical. You know, we could talk. Imagine we could talk for an hour and a half on injection. I mean, this is incredible.
It's freaking fascinating.
It is. So it's like, so guys, you come out quick. You're short. You hit that. You know, the angle of the bevel of the needle. Sharp needle. That's the argument for guys that don't want to use the needle to pierce into the multi-use vinyl top. Yeah. Because they dull it. So if guys are really, I think this is a detail, but I love details and I love to be service oriented for my patients. So they want to change, they want to inject with one and do another, and you want to have a sharp needle, just get boom right in, maybe break the angle a little bit so the bevel's up and you're breaking that angle a little bit less obviously than the 45, the 90.
Okay.
A little less.
So don't go straight into don't do a 90-degree injection. No. Yeah, you want a little bit of an angle. Okay.
A little bit. It doesn't matter what. And you want to use the bevel up, so you're just it's slicing in versus a blunt trauma.
Okay.
So you're accessing. I mean, this is all physics. This is just common sense, kind of like a steel worker. You want to go into that substrate, which is your muscle, your arm, or your leg, or your rear end, your glute. You want to just real quick. You want to. Sometimes guys tell me they do an injection. Wow, perfect. I don't feel it, minimal nerves, and then I inject and I come out tight, not one smidgen of blood, and it's perfect. But you don't get it every time.
So the one thing I want to make sure we cover with that is, so if you do have this sterile abscess, and a lot of guys watching this, I'm sure we do. So if you inject into a sterile abscess, which is this scar tissue, right? It's fibrous tissue.
Yes.
Would the steroid ever get out of there? Is it ever going to?
No, it's a good question. It probably does, but there's capillaries in there. There's blood flow in there.
Okay.
But is the blood flow abnormal, and is it perfectly? I love. You can go. Imagine we're talking about this.
I have the side story. You remember Craig? You know who Craig Titus is, right?
Yeah.
Craig, one of the times he was, he went to jail a couple times before the last time, and one of the times he was in for parole violation because he was tested for steroid. One of the terms of his parole was he couldn't be on steroids, I guess, and they tested him and he tested positive. And his lawyer argued to the judge that he had had a deep tissue massage, and the massage therapist had been working on his glutes and had freed up a bunch of trapped steroids that were in scar tissue in his glutes, and that went into his bloodstream and caused him to test positive.
Wow, that's awesome.
Could that happen?
You know what? I have to look up and go, I don't know. Maybe. For how long? I would think, honestly, I think that's just a phenomenal lawyer. These lawyers are just, these guys are just bullshit, biggest bullshit guys in the world.
That guy earned his money. He earned his $300 an hour.
These guys, they sit up in Rockland with beer, and the seagulls with me, and just blah, 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 blah. They just think of, this is just incredible thinking. So, it's theoretical, but there's no studies. And I would think after how many months of the last injection, the answer to that is bullshit bunkers.
Yeah, I don't even remember. I wish I could tell you if the judge bought it or not. I don't remember. I don't think the judge did, though. I think he went. Yeah. I believe he went right back to prison after that.
Good try, counselor. But your guy's going back to jail. Sorry.
Final question, everybody, from Albertos. What can you do in order to raise free test inside the body and reduce estrogen? Any supplements, food, or drugs that help with this?
All right, here we go, folks. Going to give you more of the brain here. So I always love this stuff, and I write down some of the notes last night thinking about it. So, again, free testosterone, it comes to mind. You got to go back to the physiology of the total versus the free, right?
Yeah.
So and we all think in the medical world, at least anyway, that it's not the total that matters, because the total is bound up on the carrier, sexual and binding globin, and actually other globins. It's mainly sexual and binding globin, and that's kind of holding on to the total testosterone. Remember, it's an oil, and you're in a medium of a saline, of a water medium, which is your blood. So it has to leave that capillary in a split. This is very spiritual. It has to leave the capillary, come off the carrier, go through that membrane into another. For an example, a skeletal muscle, it has to cross what's called a phospholipid bilayer, and it has to be lipophilic to do that for a nanopicosecond, and then it has to hit the androgen receptor to deliver its goods. So that's going to be free testosterone. That's why when you see on the labs, you guys, you see nanograms versus picograms. So it's literally 3,000. The decimal goes over by 3 points. You're measuring free. So everyone's going to agree, at least for conceptual purposes, that when you look at a man, you really should, if anything, look at the free testosterone versus the total. But for most cases, you're going to see you'll see on the Gaussian curve, you'll see that the total and free are usually are in the same area. If you're right down the middle, it's right in the middle. If he's up to normal, but when you get older, when you have medical disease, when you're on corticosteroids, narcotics, pain medicine, antidepressants, when you have obesity, when you have diabetes, yeah, you see a disparity. Then you see then you start seeing the free level being disparate with estrogen levels, and oh my God, it's so complicated. So I have to define the terms. The next step is, okay, how do you liberate? This is medical. This is expert endocrinology experts in testosterone, if they indeed are still doing it. Most endocrine guys don't do testosterone. They do diabetes and thyroid and parathyroid, and they do osteoporosis. They're getting away from testosterone because it's, as I've shown the world, it's a specialty in itself, and it's not just endocrinology. It affects the red blood cells. It affects the heart, the prostate, so complicated, kidney. So with this, when you look at how do you free and liberate and maximize your free testosterone, well, you have to get it off the carrier. So if you have a huge affinity for your carrier, and this goes back to Michael Scally all over the world, that I do give credit to him for this, you have to use other agents to liberate it from the carrier. Right, Ron?
Yeah.
It's complicated stuff, but it's very simple. You want to increase that. How do you do it? Foods. First of all, carbs, poison, because carbs lead to fat, and then fat leads to more aromatization, everyone's going to love this. If you Google and you research this stuff, it's true. In the beginning, when a man comes in, no steroid using, and he has, say, low T or low normal, doesn't feel good. He's overweight, and he may have diabetes type 2 or pre-diabetes, sleep apnea, metabolic guy, right? Metabolic stuff. Sure. You know what the first thing you tell that guy is? Lose weight, and your testosterone gets better. And it's true. So does it substantially get better? Is it sustainable? Can he make those moves to lose all that weight now that he's low T? Now we have this vicious cycle going, because when you're low T, you're gonna grow more adipose tissue. See this? See the vicious cycle? Yeah. This is just, forget steroid. This is just low T. I have a lot of just normal guys that have low T. I just don't take care of users. So if you look at that, carbs need to be low, higher protein, high intensity interval training, and then there's the Arimidex study. So years and years ago, endocrinology doctors in the world said, if a man comes in and he has low normal T and he has high estrogen, let's not give him testosterone. Let's give him aromatase inhibitors. And what it did was, to a small degree, which is true, they blocked the estrogen and they liberated, as I say, they increased the free. It worked. Wow. It worked. So and there are men that come to me that are middle-aged, they have low T, mainly from they're mainly diabetes and sleep apnea, maybe again from using corticosteroids or pain medicine. I have a lot of men in mind right now. Yeah. And they don't want to be on testosterone because they don't want to shut themselves down further. So I say, look, we could do it, and sure enough, if their estrogen levels are high because they're aromatizers and they're heavy and they have body fat, lose weight. Let's use I've used this for men, and you know what? It works. And I also use, here's a big point, I use Clomid for men that are steroid naive, which means this. Anabolic steroid users, to recover them, this is for doctors, to recover them with a SARM, with Clomid, is suicidal. Suicidal. Because remember, going back to the first part, their brains have changed from the influence of androgens for years, in some cases, in most cases, and to give them a selective estrogen receptor modulator to block estrogen in the brain to therefore increase their own testosterone, it will go up. But the blocking estrogen in their brain with the past history of steroid use leads to massive depression, even suicide. Wow. So I have men that are 50 right now, 50s, 60s. I have a bunch. They don't want the balls to get shrunk. They have low T. Right. And they have low T because they're 59. They're a little heavy. A few of the guys lost a lot of weight. Now they're in better shape. Their T is still low. Doc, what can we use? Clomid. And you know what? For these guys, they have never used steroids. Clomid works great. Okay. I've already explained this to people in the world. Yeah. So if you're a steroid user, your doctor wants to use Clomid, it's not his fault. He doesn't know. He's not the anabolic doc. He hasn't seen thousands and thousands. This is what I do. Yeah. He hasn't seen the thousands. And I've written this stuff up. I've published this stuff. But HCG is better for that man. Okay. Because you just bypass the brain, you tell the balls to work, kapow. The man produces, and you can produce higher levels of endogenous testosterone from him. And then those guys, that's how you really rescue a man on anabolic steroids. You don't use Clomid. I'm not saying you can't use Clomid, but I'm saying you have to be careful, because if you hear the stories of men and they're listening right now, they're going to go, oh my God, the doc, he's right. When the doc is a good guy, he's trying to use a little baby doses of Clomid or whatever, 50, 100, maybe more. He may get a good response on paper, but the guy's typically going to feel like crap. And his mood and libido, none. He'll be the erectile dysfunctional guy. So the other issue is to liberate the free testosterone and to block the estrogen. Again, medicines. You got to do a history. Pain medicines, corticosteroids, narcotics, other medical issues, sleep, and another big thing is, again, the depression, sleep. When someone says, Doc, I have these problems, if they could sleep better and if they could restore that circadian rhythm, Ron. Yeah. But then again, that comes to stress and life, and then that's why you need to go up with the pigeons and the birds up in Rockland.
If everybody could just do that, you know, a few times a year, they'd be cool.
And that's all I have to say. What else, Ron? Any other? What do you think? What do you think about that?
Increasing free tests. I mean, you know, there's a lot of supplements that purport to be able to do that.
There are.
And some of them do have a nominal effect on free tests, don't they?
They definitely do. They're actually, I'm not an expert in that stuff, you know. I mean, there's Tribulus, there's a lot of different medicines, but the problem with a lot of those, they're definitely great steroid alternatives. They are. But in the end of the day, are they sustainable? Are they sustainable? Actually, you know what, Ron? That is a good point. And I actually, with that, I definitely took, let me just get this, because I did, you reminded me, because I forgot to mention, I researched that. So to be complete, for the record, D-aspartic acid, vitamin D, funny enough, Tribulus, fenugreek, ginger, DHEA, zinc, ashwagandha, blah, blah, blah. I can't pronounce all these things because I really don't care. And they work. They work. Some of these T boosters, the truth is, they do work. Now, the thing is, compared to, it's like you can make a little money versus hit a $1 million jackpot with taking testosterone. Testosterone bypasses everything, shuts everything down, and goes right into your brain.
So when you say they're not sustainable, does that mean that, you know, if you stop taking them, you're not going to see the effect? Or even if you kept taking these things indefinitely, eventually you would stop seeing the effect regardless?
Ron, after doing this for more than 10 years, so many men come into me with a history already. Doc, I didn't want to use steroids or testosterone. These are not muscle building. These are just regular guys. Some of them may be muscle building, and it's all teased out. It's all, you can't get the shit out of the blanket, as my father used to say. It's just all in there together. It's multifactorial. So they come in, they use these agents, and they get a great bump in the beginning. How many guys are going to tell me that over 3 months, 6 months, 18 months, that they're on that exact same supplement and their T is up there, it stays up there, and they feel great? The answer to that is zero. Zero. That's Ron. I'm a free guy, man. I'm just a free player. Yeah. I mean, I will certainly tell people that these are the agents. Steroid alternatives for young guys, absolutely go for that before you do steroids. They do work to some degree. There's no question. The science is there. Yeah. But compared to the real stuff, guys, I mean, don't do the real stuff. Suck it up and understand that's your limit.
I tell everyone just use the real stuff, but that's me.
And the end of the day, Ron, you know, at the end of the day, guys will sit there in their heads. These are just normal people. They just sit there, you know, maybe with the seagulls in Rockland kind of a thought, and they just think and think and think, and they're like, and they're when you're healthy and you're young, I understand what's going on now. They're healthy and young, and they don't have that perspective yet. That's why the transition from anabolic to metabolic is when you get older. You know, I was in Rockland. I had a beer, and I was on you see my Instagram on Rockland. I had a beer. I read a guy's email. He understood the anabolic and metabolic, and I did my Instagram saying, wow, he's right. This is great. Thank you. Young guys are so goddamn healthy, they're freight trains. Ain't nothing going to stop them. But as you transition into your 40s and beyond, you start to become humble. Some guys have forced humility because they have a heart attack or a stent, or their kidneys are not going well.
That'll do it. Yeah.
I mean, I'm just trying to provide an openness, Ron. You are too. We are, of real medical care and support and openness. And you're using illicit drugs that are very powerful. Just be careful.
Yeah. All right. Well, I think this has been a good one. We covered some subjects I never even heard of until today, or until yesterday when someone posted it. So this has been a little breakthrough for the Anabolic Doc Show.
Awesome.
So everybody, I encourage you all to check out those two websites, metabolicdoc.com and anabolicdoc.com. Both of those have links to all Dr. O'Connor's social media. Go to his YouTube channel. He's putting out awesome content on a regular basis now. What's that? The logo behind me? Okay.
Yeah.
And let's thank the doc collectively for what he's doing, because nobody else is doing this right now, people. Nobody, except for maybe George in Greece. We'll get him eventually. He's got his book shipping on the way to America for me, so I'll read.
We gotta get George. We have to get George up. Ron, please work on George.
I'll get George. Now, do you want George? I'm asking this on air. Do you want George with you, or do you think I should do him on his own?
No,
Like
all
a raw
three of
line?
us. All a complete zoo. All three of them.
Might be an 8-hour video. I don't know. Have to break it up into many parts. Okay. Well, this has been a great one. Thank you, Doc, for everything you do, for doing this show, especially. Appreciate it so much. Everybody check out his websites. If you're watching this on YouTube, please subscribe to this channel. And thanks for watching, as always. We'll get you next time.